welcome to Chief Among Friends. I'm your host, Dr. Chris Hobson, Chief Medical Officer at Orion Health. On this podcast, I chat about topics ranging from technology priorities to new innovations in integrated, coordinated care to healthcare sustainability. You can follow the conversation on hashtag Chief Among Friends and be sure to follow me on Twitter at Dr. Chris Hobson. Today, I'd like to talk about the critical role of nurses in our health system, and especially their perspective on health information exchange and population health. Today, I'm very excited to have my friend Karla Vermeer with me to discuss all these questions. Karla Vermeer is a registered nurse with extensive experience in the use of EMRs such as Epic and electronic health records such as Orion Amadeus Health Information Exchange software. Also provider and patient portals and public provincial health resource websites and chronic disease registries. Since 2006, Karla's role has included the development, implementation, adoption, and optimization of digital clinical tools in Alberta, Canada. In the past 20 years, she's also worked in a family practice clinic. 12 of those years were specifically targeting care and education for patients with complex chronic conditions, including diabetes and COPD. At the clinic, she gave team-based patient care and supported the clinic's implementation and optimization of the provincial enterprise EMR and the EHR provider portal. She has excellent experience in clinical health integration tools, change management, and workflow process re-engineering. Her hands-on use complemented the collaborative work done with Alberta Health Services in the implementation of regional and provincial enterprise EMR, (EPIC). She also assisted with the optimization of the provincial EHR, Orion Netcare or Amadeus, provider portal and its attached regional diabetes registry. During this time, she also worked as clinical coordinator and information manager, coordinating digital health tool implementations in the Edmonton West Primary Care Network, which consists of 150 GPs working in 60 different community-based primary care clinics. So as you can see, Karla is one of our most experienced people. I'm very grateful to have you here with me this morning. Welcome, Karla.
Thank you.
So let's talk about the role of nursing and health information exchange. So over the last 10 years or so, the nurse's role has grown and changed dramatically. More than ever, nurses play a pivotal role in all aspects of care delivery. At the same time, the healthcare system has become much more complex. It's more important than ever to ensure that our clinicians have access to the information they need and when they need it, which in turn is key to ensuring that patients are receiving the best possible care. Nursing professional bodies are now increasingly looking for nursing professional bodies generally want to see increased use of health information exchange, electronic health records, electronic medical records. And nurses are almost always the major users of the health information exchange. So Karla, let's start with a high-level view. From your perspective, how has the HIE impacted nursing?
Wow, it's a joy to answer that question. It has had a huge impact on nursing. Nursing has changed, like you mentioned, a lot over the last years. Traditionally, it was, nurses were just taking orders and doing tasks based on orders. Now nurses are very much doing team care and having the health information available at their fingertips has supported their expanded scope. We have nurses now working to full scope capacity. So they need to have excellent patient information at their fingertips. It's a gift. The health information exchange, in my mind, is purely a gift. I've said that for the last 14 years, working with people, and when I've been training them, rolling it out, they're like, seriously? This is amazing that I have all this data, because nurses typically work within a unit or a clinic or a subset of a patient's care. They don't necessarily have their own provider roles or their own patient list. They're working in conjunction with somebody as RNs typically. So having access to data is very helpful because patients are maybe under multiple caregivers or even visiting various regions or different facilities.
Absolutely, absolutely. So perhaps if we turn to look at the Alberta government or Alberta provincial Netcare, which is a health information exchange or an electronic health record, and let's understand a nursing perspective on Alberta Netcare. So Alberta Netcare is a province-wide health information exchange, has been in place since 2006, more or less. It's been hugely successful with more than 50,000 regular users across a broad spectrum of end-user roles with peak loads of 5,000 concurrent users. So as a nurse and having access to all of this information, can you give us your perspective on Netcare, especially some of the keys to its success? And are there any big outstanding things that you'd like to see available that perhaps are not there?
Yeah, I mean, if I go back to when we first implemented it, I remember being on the surgery ward and it was meeting new patients being admitted. And then you had to sit down and take a lot of time, take a history. What's your current med list? Who's on your care team? What's your history diagnosis? Those kind of things. Very time consuming, right? Right there as a patient's being admitted. Now, accelerate forward and you'll see Netcare or the HIE available with a list of medications, pertinent diagnosis, current problems, even people on care teams or current labs. You can learn so much even before you've sat down to meet with a patient. You've got all this information already ahead of you and you can just validate it when you're meeting with a patient. Huge benefit on a surgical ward. Now, I used to work surgery and then I worked to primary care. Same thing. I'm meeting a patient for the first time. Boom. I know so much about them even before I've met them face to face because I know that I'm going to be meeting with them maybe for the first time today. And I can look onto the HIE and understand what their clinical status is, what their conditions are, who's on their care team, and even start prepping in my mind what some of the needs might be, anticipating that before I even meet with them. Huge benefit. When it first started in Alberta, it was based on repositories. We were very fortunate here in the province of Alberta to have rich repositories built, lab repositories, diagnostic imaging repositories, med listing of meds dispensed. So it's quite targeted, or even immunizations from certain sources. Very valuable because it did not exist before. Either we were on paper charting historically, more are on EMRs now, much more, like over 80%. But even then, most of the EMRs in the province have been silo EMRs or clinic-centric. They're not an enterprise EMR. That's new. That's come in the last several years, the enterprise EMR that's being rolled out here in Alberta now. And I've been on that application as well. Still going back to Netcare because it's different data from different sources. If I'm only seeing data based on stuff that's been done within my one source or clinic, I'm missing a lot of things. Patients move. Guess what? They don't stand still. So when I'm meeting somebody for the first time or dealing with a patient that I even maybe have been seeing for quite a while already, they may have been getting care, medication orders, other prescriptions filled, or lab testing done or diagnostic imaging done outside of my clinic order entry. It might have been in a different region, a different pharmacy, a different feed. And I can now see that in the whole province of Alberta. So valuable. It's a gift.
So I'm very interested that you see it as saving time, because we talk a lot about, for clinicians, time being probably their most useful, most valuable commodity that a clinician can have is their time. But how does Netcare save time?
Oh, absolutely. I remember rolling it out. Even now, there's still sometimes people when I've been working with rolling it out or helping them optimize or get onto the tool. I have had nurses or physicians say to me, oh, I don't have time to go to another source and check it out. I'll just work within my own EMR. And my answer to them is you can't afford the time to not do that. Quite frankly, like there is so much that you can save so much time just by, you won't have to repeat order. It's in my EMR, I might not have an X-ray for a mammogram for a screening tool, or maybe a certain lab creatinine value. Oh, I need to send the patient and have them do this. No, it may have already been done, and you've got it right there at your fingertips. You may save time. And to me, bottom line, you can't afford not to use it for time saving.
And I'm interested also, Karla, for a while there, for several years there, you were working in what we used to call the soprano chronic disease management application. How did you find that, especially with it being linked to the HIE, the two things working well together, or were there sort of special observations from your perspective?
Oh, that was such a gift to the multiple nurses that I was working with. We started with diabetes and built off of the Orion product, a soprano-based diabetes registry. And it was a validated enrollment. It was a tool that we could use within our clinics to track the patients that have diabetes for a specific clinic or a specific physician. And that came at a time when many of the clinics at the time were still paper charting. Some of them didn't have any way to do patient lists or anything. So it gave a secure format to list patients, identify who they are, and also have auto-populated in the indicators that pertain to diabetes, whether it was blood sugars, blood pressures, weights, are they smokers, whether they're risk factors. And it was all on a dashboard per patient, per physician, per clinic, or per region. And where this stuff had never been available before. Because of leveraging databases, we could auto-populate these lists and start navigating populations of health patient panels. Those that were associated with a family doctor, they got identified that way and managed within that clinic by nurses. And those that were unattached showed that. So in the region, they could decide if they wanted to target those patients with a different approach. Oh, I'm just making this up, 60% unattached or 20% unattached. That's what we need to target and work on. A region could say that, aside from what we were doing in our clinics, in the private clinics, working with providers that had attachment to a patient.
So an individual provider could target some of their own diabetic patients who needed attention, but also a more population level manager could also see across the region and see which patients maybe don't have a primary care physician, for instance.
That's correct. And the tool was such that it really honored privacy, and it honored, accessing appropriately. So there was, you could not lock it down specifically to a clinic and to a nurse who had been approved by that clinic or by those physicians to actually see their panel of patients. It could narrow it down that tight. But if at a regional level it was de-identified, you couldn't drill down into a patient. You could find out patients that were unattached. And if as an administration they decided, we're going to decide to tackle these patients and take them on, they could do that. The tool was customizable to whatever the business needs were of the community or of the region.
And so switching just slightly back to Netcare, the Alberta provincial HIE again. So I imagine that not all patients benefit from the HIE, some maybe more than others. From your perspective and from nursing perspective, are there characteristics of patients where you needed to go to Netcare?
Absolutely. There's different patients that have different values of ones that would benefit. There'd be our complex patients. Maybe they have, we can benefit from lab trending. Because if I'm just on my own EMR, only seeing the lab results on that specific complex patient on my EMR, I might be missing something that was done by a specialist across the city or across the province, right? And I can actually now dip into that and leverage that for decision making. It also was of value from a patient perspective. If I was seeing a new patient, I could really get to know them before I even encountered them. We could leverage the HIE also to do screening, population or panel management or population management, saying who's due for a screening test, because we added in a screening tool. It looked and saw who is of a certain age, who's due for a PAP or a mammogram or a PSA or lipid check or glucose check, and who's not had those done in a certain
Mm.
time frames that are as per the guidelines. And that was on the HIE, where that might have given false alerts on an EMR or a charting tool, because those might have been done outside of a clinic per se.
What about some very specific groups that maybe are finally becoming more on our radar? I'm thinking of the Indigenous population, and then also maybe the homeless or patients at the bottom of the socioeconomic kind of rankings. How does the HIE
Yeah, I
help
think
them?
that would be something. Yeah, and I didn't per se myself. I didn't deal with that. I'm aware they were doing work with the Indigenous population here. I was living in a city, not working with them, but I'm aware that was going on. Homeless, there was a way that they could tag them as well if they were unattached or if they didn't have an address. There was ways that they could filter and sort them on the HIE or the EMR. There's ways that they could be filtered and accessed that way, or maybe directed to, was partially involved in some clinics that were built to meet the homeless needs. And they leveraged the HIEs because these people were not necessarily attached to a physician. So the homeless were really supported by these unique clinics.
Got it. So the unattached does keep coming as a key group, doesn't it?
No, and you can identify them and say, oh, they're missing these gaps, and we're going to be very opportunistic when we do see them, or when we do find them, or when they do appear. Boom, we're going to do as much as we can for them today because they're here.
And what sort of proportion of people would be unattached in a city, urban clinic today? Would you find a large proportion of the patients were unattached, or very few?
I don't have those. There is data on that, but I don't have that at my fingertips, and I don't want to speak out of turn.
No, that's fine. Yeah. What would be the most useful data, especially from a nursing perspective, but in general, in terms of, by itself, data is just data. But one of the things we've learned, I think, over the last 2 or 3 decades of doing health information technology, some data is much more valuable than others, and data changes its nature as it moves through the system. So from a nursing perspective, what are you looking for? What do you most value in the HIE?
Probably the most valued would be the meds that are displayed on it. I mean, there's multiple, so many, but one, if I could talk about medications, is what meds is this patient been dispensed? And on the HIE that we have here in Alberta, it displayed meds dispensed, which was different than meds ordered or prescribed. It was showing what had been filled. So that became already a conversation. If I was looking at meds dispensed, is this patient, they have a history of hypertension or dyslipidemia, I'm just making this up, or diabetes, and are they actually taking their meds, or they have asthma, are they taking their meds? Wow, you haven't filled your inhalers since 2 years ago. I can see that right now. Like, how can we help you here? Like, it may be a point of conversation. Or they're saying, I'm taking all my meds for my blood sugars, and you realize you actually haven't had any of your diabetes meds filled for the last 6 months. I can see that here. Or I can see that you actually are on these certain medications. That's going to have an implication on how we care for you now today with your diabetes, because you're on a medication that could potentially cause a low. So we need to deal with that today, or whatever. Having that med list there is huge. Having lab results on the HIE is huge. I can see lab results no matter where they were done, whether they were ordered within my clinic or not. I can see if they're due for something based on lab results. I can see trending. Sometimes if it's just our own lab ordered, there may be gaps of care or gaps of data feeds, but on the HIE, it's all there, and I can see it timelined out and start to see what's the status of this patient. How's their kidney function doing? How are they doing with their blood sugar control? Other data would be the ADT feeds, knowing where they've been. Oh, we're meeting now and we're talking about your asthma, and you're saying it's well controlled, but I see that you've had 2 emerge visits this year, and they're related to asthma. Can we talk about that? Right? So it becomes a point of, and I usually bring up the HIE right there in front of the patient. We can have that conversation together if I have questions and validate it with them. The other thing is caregivers, knowing who's on the care team. When I'm working with complex patients, a lot of them now are no longer in the hospitals or being cared there. They're being cared for at home home care nurses, and I want to know who their home care coordinator is. Who can I contact when something's changed or when I have questions? Having that right at my fingertips is huge as well.
Actually, that is very, very interesting. So, what you're saying is that you found that the health information exchange was an ideal tool for discussing with patients some of the things that's happening with their condition.
Absolutely. I mean, if they come to me as a new patient, we can talk through, oh, I see you've come from southern Alberta and these are the meds that you've gotten at this pharmacy. It can be brought into the conversation now. Or they may have had an episode, an incident, and they were at a clinic out of city or maybe across the city, not at ours, and you had this done. Let's look at it together. What did they prescribe, and are you taking what they advised of you? Now I can update my EMR based on what we've discovered together.
Now, I know with with Netcare there has been very occasionally some concerns about people accessing the data inappropriately. From a clinician perspective, how do you see the security and the trust in the data and in what you're seeing with respect to Netcare? Is it something that you've always been able to trust, or have there ever been concerns?
Yeah, you know what? It's always been very secure. A couple things. You can't get onto the provider portal without being granted access. And that's done with your being as a provider, as a role, or as a clinician or a clerical support, whatever it is, you are granted access by somebody who is a custodian. So you don't just willy-nilly go onto this tool. You are granted access for a period of time, and it's typically linked with a facility or a caregiver that you're working with. I see that very secure. The other thing is it's audited. Anytime I look at even a patient's name and demographic, or even a screenshot, maybe it's a certain lab or an x-ray, whatever I looked at, it's auditable, it's stamped. The portal honors masking people that want their record to be masked or secured and not accessed. And then it's audited that way. If somebody goes into it, number one, they're stopped and you have to answer questions. Are you sure you want to go? This is a closed chart. And you say, yes, because I'm a clinician, or yes, the patient gave me permission. It's audited. Plus, the patients are notified, and those that are tracking this, it's audited if it's a masked patient. Or if you've accessed somebody who maybe is a neighbor, same geography or same last name, it fires audits. And the privacy officer at your facility who's granted you access will come and speak to you about it. So it's auditable, it's secure. Some hospitals, for instance, have it locked down to a unit. You can only access patients that are on your unit during that time. That's a functionality that's there. In general, in primary care, you can search for whoever you need to. There's the code of ethics, right? And if you step outside of that, or if there's a complaint, we can always timestamp who logged in and who did you see, and you can validate if you're actually caring for the patient at the time, because the rule set is you only touch those patients you're caring for that are under your care.
So, from the perspective of a frontline clinician using the system, there's more than enough warnings, alerts, passwords, and so on required that there was never any concern from a security perspective or privacy perspective.
Yep. There totally is that. And there's ways that you can also set it up if you're working in a clinic setting or wherever, where it, after 30 seconds, 3 minutes, a time frame, if the screen is open, it'll lock, or you can log off and protect your login, you secure your station. All those rules of privacy training is very high. The standard is very high. And I think that speaks to the success that we've had in Alberta. The tool set has the technology to promote security and privacy, but also training is behind it.
Okay, that's great. So another topic that was of interest to myself, and that is coordinating patients, especially as they move perhaps from the hospital to community, or in the other direction, or around the healthcare system. I think it appears to me that nurses are often in a key role of making sure that the patient does have everything they need in order to securely transition. What's your perspective with respect to healthcare transitions and the role of the nurse?
Yeah, I think you're right. Often that falls on the shoulders of nurses, and it's often a navigating role or an advocacy role, um, care coordinator role, whatever you want to call it. That often falls on the shoulder of nurses. The doctors will order it, and they assume that it's being done, and they assume that the transition is happening safely. But there's often, with one patient, the patient's always at the center. They can have more than one caregiver. And they can have more than one facility involved, and it can get very complicated very quickly. And having the information there, I can know, I can log in and find out which pharmacy are you using. Yeah, that's where you're getting your fills. Got it. Oh, which physician are you seeing? I see somebody else is ordering a lot of lab tests here, and you find out they're seeing a urologist and a cardiologist and an endocrinologist. It can get very complicated, knowing who's even on their care team, but having HIE, we can start to infer that. Or the ADT feeds, what we call ADT feeds. It's when they've been admitted to a site, it'll display, or they've just checked in at this Emerge, or they've seen a specialist at this facility, and we get that feed, and we know what their activities have been. Transitions of care, I want to be able to support that. I want to be able to validate when a patient comes to me and say, I saw this person and they gave me this little white pill.
Yeah.
I can now, in the transition of care, let's go look at it together on the pharmacy feed. Is it this one? We can validate this information together, because the patient's in the center of it as well. And they have their perspective of the information, but they don't, and we happen to have several patient portals now. Those are new in Alberta, but in general, it's the provider portal that becomes the glue for each of the patients, and they're being supported. Their care is being supported by this in the transitions.
That's interesting, isn't it? Because the care transitions is also where things tend to go wrong and things get dropped.
Yep.
So
the HIE becomes a place where you can validate who's on the care team, where this is supposed to be going. Did they actually do what we thought they were going to do? It becomes a validation point.
And I think related to that, and it's also important, I think, with nursing, and that's the team-based care. So we're keen to have more multidisciplinary teams and so on, but does the HIE have kind of unique characteristics there, or helps team-based care?
Absolutely. And I think of team-based care, here in Alberta, we've talked a lot about the medical home, and there's 3 T's of the medical home: teams, technology, and targeted approach. But I can extrapolate that to any setting in my mind. That can be in a hospital setting. It can be at a endocrinology clinic, a specialty clinic, or primary care clinic. And those teams are becoming much more prolific now. Capacity is one reason. We don't have enough doctors. There's the patient needs, and also having people work to full scope. So having the HIE for our team means we're all looking at the same information. And historically in the past, nurses had their perspective, physiotherapists and respiratory techs had their perspective, the physician had theirs, and we were all charting separately. Now it's about the patients at the center. Let's all look at the information that we need, and let's filter and look at what's going to help us help the patient. Team-based care, it may be that I'm going ahead of the physicians and identifying a group of patients, population health. Let's talk population health. I'm identifying people who are due for an intervention, or are due for a med refill, or are due or out of target. Maybe they are on a diabetes list, for instance, and their sugars are too high or their blood pressure is too high. I can run reports and bring that back to the physicians who are in charge of that care and say, hey, we need to target these patients. That's one way as a team member I can support, or it can be right there in the room. They're in the exam room today and they're seeing the doctor, and I know that they've just come from another region or had something else occur in their health that the doctor's not aware of. I can do the footwork ahead of time and bring that and prep the chart for the physician by leveraging the HIE. Nurses tend to be really good at that. I think they're really good, and physicians we've had to bring along. Lots of physicians are excellent at technology. Lots of them are not. They say they don't have time for it, and they rely on nursing staff or allied health or their support staff to feed them the information they need. And that's a start for the HIE, it's not where we ultimately want to be. I'd rather have a physician on the tool himself on the HIE doing his own care. If you're dealing with a patient, see the trending, see what else is available out there for you. Nurses are a great support, and they'll advocate and leverage that information because they're good at it. I think they're good at it, but it comes down to team approach, and technology supports that. The HIE supports that.
So in the EMR, EHR world, we're hearing a lot from physicians that they're overburdened by the computer, especially the major kind of clinical information systems that they're supposed to use most of the time. And the physicians are often saying, well, what I need is a medical scribe or some person who will do the work of interacting with the computer for me. And then with the HIE, we're told, well, that adds additional load to the clinician, so why should I do that? And as well, now you're asking me to look at two systems. So the question is, so what do you think about that? Do you think that the HIE is any easier to use? Maybe it could be a first step. I'm not sure. What are your thoughts?
Oh, I think the HIE, depending on how it's been developed, like it needs clinician input. It's not just data. I think in general, not even talking healthcare in general, there's lots of data, but you have to make sense to the context of what you're trying to accomplish. If it's healthcare and it's a physician view, then you've got to have the data. There's so much data. You have to have it displayed in a way that makes sense. And we have that in our HIE on the Orion tool here. We've got a clinical documents tree, which can sort by, maybe I need to know timeframes, date. Maybe I need to know by care providers, specialists. I can sort by that, a filter. Maybe I need to know just by what the data is. Is it a lab? Is it a medication? Is it an encounter? Is it an X-ray? Is it a care team things? Like just being able to have it displayed in a format that I can leverage and filter makes it that much more accessible. Having said that, 14 years ago when we started this, the provider portal was very simple. There was not a lot of data, because it was still being built, and it was already high value. And they said, well, within 20 minutes, you'll learn how to use it. Got it. It's not like that anymore, I don't think. I think you need to take on the commitment as a provider and a clinician to learn it. Learn it as a tool. Let it be something in your toolbox that you use. It's not that you dip into it all the time the same way for every patient. It's not like your EMR charting tool. That's not what it's designed for. It's to top up information, know what's available, and as important, know what's available is to know what's not available. If it displays medications, what does that mean? Does it mean meds dispensed? Does it mean meds stopped? Is this a reconciled medication list? Like you have to know what you're looking at. Or if it says, immunization record. Well, what's maybe missing? Okay, it's not showing maybe what's been coming in from private clinics, or it's not all the data is there, but it's still, you have to know what it is as well as what it's not. And you have to learn the tool and start to navigate it, and it'll be second nature, and start learning the trending. But that comes for nurses too. That's the optimization piece. Getting them onto the tool is the first step, and saying, wow, this is so cool. But then to be able to optimize it and make it a part of your day-to-day activities, whether you're sitting with a patient or whether you've gotten a phone call or whether you're doing a chart review, whatever. You start to use the tool, not the same way each patient. That's not at all. That's where it wastes time. But know what you need and be able to dip in and out of it when you need it.
It makes absolute sense, doesn't it? So we should spend time making sure that both the HIE and the hospital system or the enterprise system, that we fully understand them. They've had plenty of clinical input, and also some optimization sessions where you actually really, given the data, the unique data that's in your unique environment, you can actually get the maximum value out of it. It doesn't just turn it on and there it is kind of thing.
No, that's exactly right. And we've been very fortunate the last 14 years, and it continues today in Alberta, to have clinician input into the views, into how data is displayed, into preference lists, and even what data is displayed. We've got formal processes like, this would be really helpful to have, for instance, screening. That came on a couple of years ago. That didn't exist initially, but it's like, wow, the guidelines here in Alberta for generalized screening tools and the indicators, to have that added on, huge value. To have, for instance, it might be something a specialty group wants to see a certain thing on. Okay, how can we support that? So it comes from the ground up. It comes, I guess my point is, it comes from clinicians. What's their need? And you need that engagement. It's not just a technical build. You need to have clinicians speaking into it to optimize it.
So the Netcare Clinical Advisory Group, or the Netcare?
That's correct. Yeah.
So that committee's run for a long time, hasn't it? What was your experience with that?
Yeah, I was part of that committee, and it was, it's grown and evolved over the years. Initially, there was called an Integrated Clinical Working Group.
That's right.
And it was a working group that spoke to, if there was issues, we addressed them, or if we had ideas for optimization, it was discussed there. And then the Netcare Advisory Group talks about, if there's issues, complaints, or concerns coming in, we can address them. Maybe something needs to be changed, or maybe there's upgrades. Maybe there's new things that we can make this tool better. But if we do, what's the risks, the benefit? It's actually clinically thought through, because plugging in a tool is not just the only solution. It's how does it integrate with your day-to-day activities? Because I'm working on my charting tool and I'm seeing patients. How does it integrate? Is it interrupting my work, or is it supporting it? So you have to think of not just displaying the data on that tool, but how does it integrate with a workflow of a clinician, how a clinician thinks, how is it being displayed, or is the right data there? Is there an opportunity on Netcare? We actually have an opportunity, I should say. If we see data that doesn't make sense, we can say, hey, I have a suggestion here, and we can send it to our team. Or, you know what, this patient data doesn't even look right at all. I can actually, in that context, send a ticket in from the context of the EHR. So you got clinician engagement at that point. If there's things escalate, then it goes to the advisory committee, whether there is a concern or maybe we want something new, and then it was scored and triaged. And we've been able to add in things over the years based on clinician input.
So that seems, I think we do sometimes fall into, I wouldn't say it's a trap, but a way of thinking, oh, well, so once we have, I'm making this up to some extent, once we have medication data in the HIE, then the physicians or clinicians will adopt it. And I think what you're saying is, yes, there's capabilities and there's data sources or new types of data, but there's also a very clear need for a process where that data or new thing gets looked at and fits into the bigger picture of what Netcare is doing overall.
Yep.
And this is an
ongoing. And that might be informally, where it's available as information on a banner when people log in, or it might be formally. My favorite is leveraging existing organizations. Maybe there's Alberta Medical Association, or College of Physicians, or primary care networks, whatever, or CARNA, nursing approach. How can we leverage existing places to highlight things that need optimization or adoption? Trying to do it on your own is very difficult, but if you can leverage existing organizations, they can help you with that.
And another observation from watching Netcare over the years is that there's a very broad range of clinician roles and the end user types. And that seems to still be growing. Would that be true? Or did you?
Yeah, I don't know if it's growing. I think it's it was quite narrow initially, but everybody has, like, there's a lot of data there. I guess my point is, initially, there's a lot of data, and not everybody needs to see everything. And not everybody should see everything. But if my role is purely to register patients and document the registration, then that's all I need to see. So you've got to have a role that accommodates that. If my role is to just track activities and check in just patient activity, then maybe it's more of just a clerical role. And I don't mean just in a negative way. Each role is important in a different way. If I'm a physician or a nurse or a clinician making clinical decisions on medications, needing to view labs, then that's a robust role as well. Like it's got to have more information available. If I'm expected in the past they were saying, oh, well, it's just a nurse or just a respiratory therapist or just a dietitian. I'm just giving examples here as they pop into my mind. I just need these views. No, because it's the whole person. It's very helpful for a dietitian to understand what their potassium levels are. She's doing, so she needs to have access to labs. Don't just lock her down to nutrition things, right?
So you would argue for a fairly expansive view of the data, especially by, for instance, how do we call these? The nurses, sorry, not the nurses, but like the dietitians and the physios and so on.
Clinicians,
those clinicians do also need a good broad access to the data.
Absolutely, yeah. And I think we've done well with aligning those roles now to that, and on Netcare, where initially, we struggled, and initially when we first got it, and with our EMRs as well, like there was hundreds of roles. It's like, okay, that's not even manageable. How do I even sign somebody up for that? Often, in reality, what we discovered is people do various roles. They might do scheduling roles, some clerical roles. They might need to enroll and register patients and do clinical as well. So you have to be nimble enough to accommodate all that. If you've got it too locked down, our clinicians can't even function on it.
And it also sounds that this is an ongoing, you could call it agile or iterative or evolutionary process, though, of continually kind of looking at issues, problems, addressing them, and then moving on with the development of the software. Yeah.
It has to be, because if you, as soon as you stop and make a decision and think that that's a final decision, okay, next week the facts change, and now it's out of date, and it's obsolete. It can be obsolete very, very quickly if you're not staying nimble.
Well, look, Karla, that's been really very interesting. So thank you for joining me today on Chief Among Friends. For more information, don't hesitate to contact me on Twitter at Dr. Chris Hobson, LinkedIn, or visit our website at www.orionhealth.com.